I'm Zithis Kozlakidis, the editor-in-chief for the Journal of Innovations in Digital Health, Diagnostics and Biomarkers. The Innovative Healthcare Institute is a US-based organization with a strong network of internationally renowned experts. We all focus on advancing innovative ways to improve human health and delivery of healthcare. Also in disseminating latest advances in the field through the publication of innovation journals, sharing the latest innovation news and encouraging networking and collaboration. The topic of today is all about the innovative uses of communication technology within a medical environment. And the reason why has been the increased advancement of technology within the medical healthcare profession. COVID-19 has been a catalyst in this process. So we try to identify ways of how we can use such technologies to communicate with our peers, and that would be the talk that Alan provides, and also how to use such technologies to communicate with our patients, and that would be the second talk of the day with Atlal. And that is within the general framework of the wider healthcare environment. I would leave it at that. I wish that we have a very fruitful and enjoyable discussion. We are absolutely open for questions at the end or during the presentations, and wish you a great webinar. Thank you very much. Alan, the floor is yours, and please provide a very short introduction about yourself.
Certainly. Thank you for having me. My name is Alan O'Donnell. I'm a physician assistant at Cincinnati Children's Hospital in cardiothoracic surgery. So the majority of our patients are kids, but we have sort of bled into the adult congenital world. So I am going to, let me share my screen here. I will be talking to you just about how to use surgical videos. Let me see. Can you guys still see this screen? Okay. Okay. How to use congenital heart surgery videos and their roles in education. My interest in these surgical videos has been ongoing. I've been doing this for about 3 years now. And I'll just get right into it. So the picture you're looking at here is from a journal that one of our surgeons wrote back in 2005. It's actually the sort of the after picture of a hypoplastic left heart syndrome after a Norwood procedure. And that's the video that I'll show you guys today is sort of the construction of that, and we'll talk a little bit about how to use that to educate everybody. So we'll talk a little bit about goals of these videos and the current limitations. We'll talk about the audience, and one of the big reasons why I started doing these videos is to take the abstracts, what you see in textbooks, what you see in, you know, all these different drawings, all these different journals, and try to attach a more tangible picture to it. So then the video I'll show you is the Norwood procedure with the sono modification. And then I'll talk just a little bit about future goals. One thing I did want to talk about is sort of why get into the videos. And one of the things that I have sort of, I don't want to say become obsessed with, but have become really, really interested in was that when I first started doing this, it sort of boggled my mind that I was, even though I was in these operations and I was assisting in these operations, I still wasn't entirely sure what I was looking at. And it really was, it's a very strange thing to see something with your eyes and then not be able to go back and sort of understand what it was that you were looking at. And so these are just a couple of, this is my kitchen counter. My wife is a very patient person for putting up with this, but I built these little models to sort of demonstrate what what we were doing, and so the Norwood procedure is particularly of interest to me because that was the first video that I ever did when I had been here for about 4 or 5 months. And our surgeon asked me and our ACGME fellow to make a video for a conference, and it just sort of went from there. So the current, like, the goals and current limitations of the surgical videos, the goals are to educate and just provide a deeper understanding of each surgery. Especially with kids with congenital heart disease, I think a lot of people think of, sort of your atrial septal defect, your ventricular septal defect, tetralogy. But, there are a lot of really, really complex procedures that happen here, like neonatal surgery, that I think we do fairly routinely, but I don't think a lot of people see ever. And so just being able to disseminate that, I think, is useful for anybody who's going to, be involved in the care of these patients. So physicians, advanced practice providers, nurses, anybody. And I mean, just sort of, there's just some people who are still caring for them, but may not necessarily have a medical background. So even I've had quite a few parents and patients want to see what their surgery was like, and like I said, bringing that abstract into reality. So the current limitations of these videos, and this sort of applies to all surgical videos, that usually the runtime are just completely prohibitive. No one is ever going to watch, a typical Norwood procedure is anywhere from 8 to 10 hours, with about 8, 9, 10 minutes of really key footage that can give you a really good understanding of the operation. So that's the one thing. And then the video editing is, so you can still take all of the surgical footage, sort of cut it down to a more palatable length, but then still being able to sort of describe that. So just being able to annotate it, and then finding personnel to edit it. So it's sort of nice for me, just because I love surgery and I love heart surgery, and so I'm more than happy to do this. But I think that Venn diagram of people who, and I had never edited videos prior to this, and so that Venn diagram of people who can edit videos versus people who have a working knowledge of whatever operation you're looking at is somewhat small. So just finding the right people. Sort of the nice thing is that as these videos have been, published and people have been seeing them, I've been finding that there's a lot more people out there interested in editing videos than I would have originally thought. So that's been pretty neat. And so then finally, there's accessibility issues. So BFW Incorporated is a company that we buy all of our headlights and head cameras from, who, I mean, in my opinion, they have the best quality head cameras, which also provides you a lot more flexibility when you're editing the videos, especially in neonatal surgery, where the structures are all very, very small. And then the storage systems of where because it takes quite an infrastructure just to store these videos, because the videos are usually about 1080p, and anywhere from like 25 to sometimes 60 gigabytes a piece. So just finding a place to store all of them is quite a feat. And then just the editing hardware and software. So what I use is Final Cut Pro, and I've used just quite a few different like third-party software plugins to create all these little animations. And I sort of have been working backwards from that, which is what I find to be sort of fun. It's like, okay, well, how do I want to show this particular, part of the surgery? And then going back and looking at all these different plugins that they have, and be like, okay, well, this obviously is not intended to demonstrate surgery in any way, but being able to sort of mold it to really, really emphasize what you're trying to get across. So the next big thing is, who's your audience? So the one really, really neat thing is that you can take one particular surgical video and you can make, you know, a dozen different videos depending on how detailed you want to be about it. So you can have a very, very, you know, a very, very broad video that's sort of just like the broad strokes. This is what it is. This is what it'll look like after, and that's it. Versus the very, very technical, you know, and especially with a couple of our surgeons who are well known for a number of different procedures, but the one I'll show you right now is what we use. It's called the HeartMate 3 placement. The HeartMate is a left ventricular assist device that is used really commonly in adults, but we are one of the places to go if you need to you need them in a kid. So like I said, the audience will dictate how each video is edited. So the first video I'm going to show you is really short, and it's sort of a joke. It's just, this is how, you know, broad you can make it. So this is both of these clips that I'm going to show you are both pulled from the same surgery, just in completely different levels of detail. So this is the first one. So that is a sad dilated heart plus a fancy machine. Stuff that in the chest, and that's a happy heart. So that's it. So then versus the next one, which is a training video that I made for the manufacturer of exactly how to place this. Let's see here, I think it's a little forward. So this is exactly how to attach the device to the heart. So again, that's a big dilated heart, and I think the patient was 9 years old. So that is the cuff that attaches to the heart. You mark it with a marker, and then you put all of these pledget supported sutures, you put them in each quadrant, and then you run each additional suture around that radius. And this is, again, this is pretty detailed, the exact, you know, distance of the mattress suture from the actual ring, and then finishing up the securement. And so then that's usually followed by, okay, well, that's what that looks like, great. So now let's see it actually in practice. So now he's marking the heart, putting sutures in. And then passing those through the ring. So now he's running those sutures along that black radial line. And then putting some surgical adhesive around it. Then he just cuts out a little hole, and that's where that is where the inflow cannula will go. So that just kind of goes to show you, again, the first clip is very broad, but that just goes to show you the power of one video. You can use it in so many different ways. So the next thing I want to show you is we'll just take a little step by step for the Norwood procedure, which is a video that I'm going to show you guys. So again, I like doing these videos because it really takes everything that you see that's all nice and clean in the textbook. It shows you what it truly looks like before and after. And what I'll show you guys is the Norwood procedure, which is the stage 1 palliation for hypoplastic left heart syndrome, or any there's variations for any single ventricle, but This operation usually occurs within the first week of life, and there's really 4 major components here. And that picture is a picture of Bill Norwood, and I really like this operation because I just think it's fascinating. And you know, Bill Norwood is still alive, and before I did a presentation on it, I actually figured out what his email address was, and I got a hold of him, and you know, I talked to him on the phone a few times, and he actually sent me some video of him actually doing the procedure, so it was pretty awesome. So the first part of the procedure is the atrial septectomy, and this is I pulled a bunch of photos from an actual from the paper that Dr. Tweddle wrote on how to do the Norwood procedure, and tried to match them up the best I could with intraoperative procedures or intraoperative pictures. We don't have to go through the exact, you know, steps here, but just sort of an idea of what all of these things look like. And so then the arch reconstruction is a really big part of it. So this is, again, just different pictures. So there's also a couple of different ways that you guys can actually, depending on if they're aortic atresia versus aortic stenosis, how to actually, how that makes it different in the arch reconstruction. So again, that's an aortic stenosis. These are different types of patches that we use. So there's thin pulmonary homograft patch. Some places will use autologous pericardium, and there's Gore-Tex and Core Matrix. These are a couple of different papers that just make some different patches of different types. And then there's the DKS, which again, we don't have to go through all this stuff. We'll just get to the video. And then the source of pulmonary blood flow. So the one thing I do want to say about this is that there's a Blalock-Taussig shunt, which is actually the first shunt that sort of gave birth to congenital heart surgery at Johns Hopkins with Doctors Blalock and Taussig and Vivian Thomas for the blue baby syndrome for tetralogy of Fallot. So this is a Sano shunt. So this is what I'll be showing you guys. So there'll be the RV to PA conduit here instead of the BT shunt. So I will show you guys the video. So this is, again, the Norwood procedure. This is performed by Dr. Tweddle, who's our chief here. And let's get to it. So it was a 6-day-old, 3.18 kilograms with HLHS. He's an MSAA. He was born at 38 weeks, transferred here. It was a day of life 6. We took him to the operating room. He was stable on room air and prostaglandin infusion to keep his ductus open, which is sort of, and then, so this is a preoperative imaging. So this is just an echo of a 3-chamber echo of his severely hypoplastic left ventricle, stenotic mitral valve. You can see that he's got a fenestrated atrial septum, which is important in anybody with HLHS. And then a competent tricuspid valve is also a really, really big thing because that'll act as a systemic valve, and a decent sized right ventricle. So this is the aortic arch. And so just a couple of measurements here, just you can see how small the ascending aorta is. It's 1.5 millimeters, which is a Z-score of -5.4. And so then we will go to the actual operation. So almost all of our operations are done through a median sternotomy. We do a subtotal thymectomy. And so you'll be able to see a little bit of the anatomy. So the first part is all just pre-bypass dissection. He puts a snare around the right pulmonary artery to increase systemic blood pressure. And so this is just sort of a anatomy scan here. It's just the ascending aortic arch, the innominate, left common carotid, left subclavian arteries are all mobilized, and snares are placed around them. And then the pulmonary root, the main pulmonary ductus arteriosus, and just sort of showing that relationship and how they all kind of connect together. Okay. And so the first part of it is sewing on a shunt. So obviously you can't put a cannula in that that really small ascending aorta. So you have to sew a shunt onto the innominate artery here. So first thing you do is isolate it, and then you make a longitudinal incision along that that artery, and then you'll sew a 3.5 millimeter Gore-Tex shunt, and then you will cannulate that that shunt. So here's a picture of the actual shunt. It's made of Gore-Tex, which is expanded polytetrafluoroethylene. And the anastomosis with the innominate artery is always done with a 8-O-proline. And he creates sort of a cobra head. So he just bevels it. He calls it a cobra head to make sure that it's a Wiley-Payton connection. And so this video falls somewhere in the middle of basic to technical. It doesn't get into the real, nitty gritty of the nuances of the operation, but it gives you a very full and detailed picture of what the operation looks like. So the patient's heparinized, they put the cannula in there. So this is them picking out the Sono shunt or the RV to PA conduit, which is ring reinforced because the kids are so small that trying to get this into their chest, you want to make sure that it doesn't compress the conduit. And so then you make a little mark, and then the right atrium is then cannulated, which is a venous limb of the cardiopulmonary bypass circuit. The left pulmonary artery is then snared, the ductus is snared, and the patient is cooled to 18 degrees Celsius. They say 18, it's usually around 20 or 30 minutes of cooling. So here the pulmonary root is divided, and then there's a subtotal closure of the branch pulmonary arteries. So there's an opening that is left for the Sono or the right ventricular pulmonary artery conduit. That's done with a continuous dual layer 6O. So then there's a site. The site is marked for the proximal conduit. Stab incisions made. They dilate it with a hemostat, and they don't need to resect any muscles. So then they put 2 proline purse string sutures around that incision. And so this is the delivering of cardioplegia, which actually stops the heart. So from the pump, the snares are lowered on the head vessels, the descending thoracic aorta is occluded, and it's delivered to the aortic root and to the coronaries. And so that'll stop the heart, they'll turn off the pump, and then they do the atrial septectomy through that cannula site, which isn't always possible. Sometimes they have to make a separate incision, but today he was able to find it. So they make sure to identify all the pulmonary veins just to sort of orient themselves, and then the atrial septum is excised in entirety. You don't want to have, so you want to have a complete wide open connection between the left and right atriums. So then they replace the vents, the ductus is ligated and divided, the ligature is left on the left side just to sort of retract that out of the way. The descending thoracic aorta is then mobilized, and the intercostal arteries are then divided. And that just allows for full mobilization of the arch. So then it's stabilized. There's a Satinsky clamp that helps reduce that tension on the arch, and they put the Yasser-Gill clamp at the base of the innominate artery. So now they start antegrade cerebral perfusion, which is just perfusing the head while they do the arch reconstruction, instead of being in deep hypothermic circulatory arrest. So then that is secured, the purse strings are tied, and the surgical adhesives applied. So again, just sort of an orientation here is where what you're looking at is the ascending aorta, the arch, and the descending thoracic aorta, which includes all that ductal tissue. So the residual tissue is excised, the isthmus is divided because this kid had a coarctation, which isn't always the case. Sometimes back in those past slides for aortic stenosis, you're able to not have to do a coarctectomy. So this is him just removing. You have to really make sure that all ductal tissue has been excised because it's really, really poor quality. It can rip very easily, so that's usually not a problem. And then the inferior surface is then incised along the arch and then sort of transitions to the lateral surface of the ascending aorta, which is extended approximately down to the kissing point, which the kissing point is something that I will describe in a second here. So then there's a cutback on the pulmonary valve. And so this is the kissing point that I was talking about, which is the incision will terminate about 2 to 3 millimeters cephalad to that pulmonary root cutback. And so those two, as part of the Damas K stancil, those will be sewn together. And then there's a cutback on that left lateral posterior surface, the descending thoracic aorta. And so this is a interdigitating aortic arch reconstruction. So the distal arch is interdigitated into the descending thoracic aorta cutback, and that's all done with continuous 7/0 proline suture as part of the arch reconstruction. And this part of the operation is pretty unique to Dr. Tweddle in terms of arch reconstructions. And so here he's doing the Damas K stancil, which is that suturing that kissing point together, the ascending aortas, and that's most of that pulmonary root cutback. So that will really the point of doing that cutback is just to make sure that the ascending aorta doesn't become occluded, because you obviously you want to get blood flow to those coronaries. So then another 2 to 3 cutback, or 2 to 3 millimeter cutback on that anterior surface is done. Again, that's just to create tissue redundancy, sort of trimmed a little bit. And then the next part of it is reconstructing the rest of the arch with a pulmonary homograft patch, which is all done, all sewn in with a continuous 7/0 proline suture. So that corner of the patch is sewn into the descending thoracic aorta. And the straight edge of the patch is sewn on the left lateral edge of the ascending aorta. And then the curved edge of the patch is sewn along the aortic arch and down the right side of the ascending aorta. And then the inferior margin of the patch is the proximal connection between the patch and the now neo-aortic root. And that will complete the arch reconstruction. So now blood flow, all blood flow that comes from the heart will now be ejected out through this neo arch and through the sono shunt, which will direct blood flow to the lungs. And so this is him going along the arch and down down the right side of the ascending aorta, getting to that junction. So around there, when he gets to the junction, he trims up the rest of the patch and then completes the anastomosis. So then once that's all done, takes off the Satinti clamp. The astrogale is removed from the base of the nominate artery, which you'll see is sort of satisfying, fills the neo-aorta. And so then the distal right pulmonary artery or right ventricle to pulmonary artery shunt is then anastomosed to the branch pulmonary arteries, which will provide pulmonary blood flow. The patient's then separated from cardiopulmonary bypass. They clip the shunt, but they leave it in there just in case. And then the chest is closed, which is one of the one other not unique thing, but we a lot of places will leave the chest open. We typically elect to close the chest. Let's see here. Oops. All right. So there's that. So future goals. You know, I just think that surgical video is a really powerful and really underutilized educational resource. And when I say underutilized, I say that's because I found that just at our hospital, we have this repository of videos from back when, you know, surgeons, I think it was back in like 2009, I think was the earliest video that I could find. And it's just sort of sitting there. You know, to me, it's a really exciting time for surgery because there's still these, you know, pioneering surgeons that are all operating or they're all still alive. And so preserving their surgical techniques or tips or tricks or, you know, it's just, I feel like it's really important. And if you, you know, for me, if you go out to, if you really want to find a well-produced or well-made, or even just like congenital heart surgery video in general, there's only a handful of places that do it. So, or that have them readily available. And so one of the things that I'm working on here is building a library of, you know, a lot of the stuff that we've been doing has been case reports, but my goal is to build a library of, you know, obviously like the more common ones, and sort of taking that thought that you can take any video and make it what you want. So you can make it into like a really technical, this is every stitch that you need to throw to close an atrial septal defect versus this is what it looks like and this is what you're going to see on your board exams, like for like a medical school student or a advanced practice provider exam. And then, you know, just finding others that are interested in specialties. Obviously, I mean, I think it's clear that I really like congenital heart surgery, but you know, just finding, I know that there are other people out there in different specialties that feel the same way that I do and would benefit from access to these type of surgical videos, and then just really taking the time. And I will say to anybody who is considering it, I will say that I probably have learned more about surgery and the nuances of surgery by making these videos and just having to look at them over and over and over and understand, you know, each thing that they're doing. That alone is really, really beneficial if you are, you know, a training surgeon or a training, you know, PA or NP in surgery. It's really, really useful. So so yeah, and another thing is just sharing knowledge. So another thing about the building library, we also have through our hospital, we have a worldwide collaborative called Heart University that also is sharing videos, and then they have a ton of content available. So if you obviously feel free to check that out, and then just sharing knowledge about what makes, you know, making these videos, how to make them. I'd be happy. I put my email address there because I'd be happy to talk to anybody. I've had you know, a handful of people email me just asking me just basic stuff, and I wish that I would have had someone to like sort of explain just like the really basic things about like Final Cut or using all these different you know, third-party plugins. It would have really streamlined the process for me. So I'm more than happy to provide that for anybody. Yeah, and these are my 4 dogs: Remington, Guadalupe, Winnie, and Pooh. They helped. So
thank you, Alan. This is fantastic.
Yeah.
I mean, the amount of personal time and effort and dedication that you have to put to even learn the simple of editing a video is quite admirable.
Thank you very much.
We'll move on to the next presentation for today.
Yes.
So we're moving on to them using innovative technologies for communication with the wider patient public, the wider public. And we have Dr. Abusanad to present that. Please feel free to introduce yourself to the audience. Yes, and the floor is yours.
Thank you very much. And I truly enjoyed the previous presentation, and definitely I agree with you. There is a lot of effort and time was put into it. My name is Atlal Abusanad. I'm a medical oncologist and associate professor of medical oncology at King Abdulaziz University from Jeddah City in Saudi Arabia. I had the pleasure of publishing my experience using social media to support a breast cancer patient in one of the innovative healthcare journal. So I'm going to share with you my experience. I'm going to talk about the transformation from having an idea into an initiative, and we're going to go through the idea itself, the application of the idea, the sustainability, as well as the continuous evaluation or assessment of the quality and future goals. We need to have background before we go into more detail about the support group. Online support groups in medicine generally are present. However, most of them are directed toward lifestyle tips, such as also weight loss, coaching, some of them smoking cessation. But the ones that are mainly focused on cancer patients, supporting cancer patients, are not that many, are not commonly utilized way. There was a report tested or actually interviewed a 21 patient with a diagnosis of cancer. And they concluded that online use was generally driven by negative emotion among those young patients with cancer. They were either looking for someone to connect with, checking for information, checking for facts related to treatments and so on. And they concluded that there is a significant need to develop resources that support the holistic needs for cancer patients. And this should be done in collaboration with the patient themselves. So involving the patient is obviously something that is very important. A few words about Saudi Arabia and the background of this country. Majority of the population, as you see from the population pyramid, is young. 70% are younger than 40 years old. And the breast cancer is the most common malignancy in women, accounting for 30% of the cancer incidence. The median age of diagnosis is 50, which is considered a young age. And actually, we see even younger age, like around 35, up to sometimes, unfortunately, 25, which is something very striking in comparison to Western society. Not only that, but Saudi Arabia is one of the largest countries with the media engagement. Active internet user almost is like 100% of the population. You see the population is around 34.54 million, and the internet user is 32.23 million. So almost 100% of the population using internet. And active social media user almost is 72% of the population. That is around 25 million. They're spending a quiet time on social media, around 3 hours daily. And the average daily time spent on the internet is 7 hours. So from that being said, and from knowing this information, additionally to the fact that cancer diagnosis is still some sort of stigma in our country. So people would like to keep silent about their cancer diagnosis, sometimes to maintain anonymity, even if they participated in any sort of online activity. Not only that, but to have a reliable and trusted native language platform is not easily found. The spoken language, of course, is Arabic. Not only that, but also we have many misconceptions, myths around cancer diagnosis and treatment that usually interfere with people looking for the correct information. Cancer support group does not exist, unfortunately, the physical ones. So I consulted some of my patients and asking them, how about if we start an online support group? And that was 4 years ago, actually over 4 years, in February 2016. Many expressed their desire to be part of a trusted group. Basically, they wanted to connect. They expressed their desire to share experience and also to obtain psychosocial support. Not only that, but also to fact check some of the misconception and the myths that they receive or they hear. Why online platform? It's obvious because we're one of the largest country in the use of the social media. Not only that, but it's because accessible and acceptable to many. And it may allow some of them to maintain anonymity while they are sharing their experience. So some sort of privacy is maintained here. An interesting report from India showed that a 14-week program was created to provide physical and psychosocial intervention by doctors, nurses, and social workers for a group of, actually they were small groups, 6 to 10 women with metastatic breast cancer, and they used WhatsApp. The intervention was short-lived. However, they concluded that it was beneficial and it may replace physical meetings. Yet another Cochrane review did not find strong evidence showing that participation in online support group was beneficial. However, the trials that included in the Cochrane review was very small, short-lived, and from different countries, different population that may created heterogeneity. Why it was, our choice was online, and we discussed this, and what platform, as you see here, WhatsApp is the most commonly used messenger app. Around 71% of the population using it. So we decided to launch a group on WhatsApp, and the model was professional patient partnership. It was supervised platform, trusted, and it's made by women and for women, and it's called Najia. Najia is the translation of a lady survivor in Arabic. It was founded in 2016. The language is Arabic and the platform is WhatsApp. The audience, women with breast cancer, and which hosts a turtle, artistically designed turtle, to give the impression of endurance and persistence that is experienced by breast cancer patients during their treatment journey, and the wish for post-treatment survival and longevity. What does it offer? Some of the functions that we kept in mind when we established the group is to have it as an educational platform providing knowledge about breast cancer. However, this provided knowledge is not only provided by professionals, but also by patients themselves, correcting misconception, addressing survivorship issues, especially the ones that are kind of sensitive or difficult to talk about, such as sexual issues with treatment, allocating community resources, like patients were telling each other where to find like specified wigs, prostheses, sharing makeup tips. Not only that, but also promoting healthy lifestyle in terms of like healthy eating, exercising, maintaining ideal body weight. Psychosocial and spiritual, providing strategies to cope with psychosocial stress. And what I found fascinating is the ability of the survivor and some of the cancer patient to provide very comprehensive and advice to their peer in dealing with a diagnosis of cancer. Promoting hope and resilience, especially if there is a news about one of the patients progressing or, God forbid, dying because of the cancer diagnosis. Assisting in coping with grief and difficult news, this has happened on many occasions, though it was difficult to receive bad news, but the coping was definitely something to admire. Forming new friendships. Initially, the members in the group did not know each other, but with time and with the expansion of the group, some of them became very close friends, and some of them were able to arrange group-led activities without professional interference or help. Of course, it's been used to announce pertaining events for breast cancer, volunteering in awareness campaign. It empowered patients because it gives them the ability to guide each other, to help in managing each other's symptoms, improved self-esteem significantly, and give them a space to express their need and emotions. Not only that, but also denouncing the stigma of breast cancer. For example, if a lady had the courage to talk about her disease while she's presenting herself by name and family name, then many will follow her lead and do the same. To sustain the group was not an easy job. We faced a few challenges in terms of misuse. For example, we had a lady who was advertising herbal supplement and claiming that it's going to be the miracle cure for cancer. So unfortunately, she had to be removed from the group. And perhaps here comes the role of the professional in the group. And not only that, but also the delegates from the patient themselves to make sure this group is going to be a place or a hub for truthful information, correct information. We faced, and we still facing, sending unrelated broadcasts and news to the group. So we've been asking them periodically or sending periodic reminder to remind them of the goals the group that was established or created for, which is basically sharing the experience. The news of a member worsening condition or death, definitely it's a big challenge, and it's been a recurring challenge from time to time. It left a negative impact sometime, but luckily it is a transient effect. Yeah, and on the other side, it opened the discussion about the fear of recurrence, the death, and in general, the existential discussion, such as any WhatsApp conversation or texting, default of emotion or facial expression, sometimes misunderstanding and interpersonal conflict may occur among the group members. However, usually we overcome this by conversation and clarification of what is meant. Quality assessment has been subjective all the time. There was no specific objective measure that we applied, but the group has expanded over time. We started with 10 members, and currently you see here, it hosts 173 participants. And this was the founding date. It was created in February 2016. So it's been going strong and still expanding. Not only that, but also included patients from different hospitals and from different regions across the kingdom, which I did not expect when I started this initially. Initially, it was intended for the patient I was taking care of. It's 4 years and 9 months old. Many on just personal interview find it empowering and educating. collateral benefits. So it definitely strengthening the physician-patient relationship. It gives a window to the thought of these women just by observing their exchange on the WhatsApp, to their concern and unspoken fears. Not only that, but as a physician, especially female physician treating breast cancer, it helped me get an idea about the places that sells quality wigs, quality makeups, specifically for patient with breast cancer. So definitely it made me resourceful. So the development process started from having an idea, and the idea was acceptable, feasible, and the impact to effort ratio was quite manageable. We chose an online application, and the model was a professional patient partnership in a supervised, trusted platform. We've been faced with challenges and definitely with successes. Assessment of quality has been subjective and it is so far favorable. In conclusion, Najia Support Group is unique for creating professional patient partnership on one hand and patient-to-patient also partnership on the other hand, leading to a multifunctional support group. It used innovation by using or applying social media in supporting cancer patients and survivor. It helped to fill or to minimize the gap between the medical treatment and the much needed support for patients with breast cancer as well as the survivor. Thank you very much.
Thank you very much. This is really such an exciting story, and also such a fantastic tale of empowerment for the patients and also for the physicians up to a point. I wanted to touch upon as we start the discussion, and I would invite all of the participants to post questions if they have. I will start with a question about what Alan said, bringing these abstract ideas into reality. He does it obviously with the videos for the surgery, but you're also bringing this abstract idea about cancer diagnosis. What would it mean for me? How would it look like? How would I look like? Into a reality with a lot of very specific tips and advice. So in your experience, how can you continue providing this advice, this grounding to a lot of the patients and provide the support in the long run? What would the sustainability look like in 5 years from now, 10 years from now? Because the platform is a fantastic tool. It brings people together. But how do we continue with that?
So far, it's almost 5 years old, and luckily is not dependent on me or other professional. It is now operating by the ladies, survivor and breast cancer patients. They have been learning how to be a delegate and how to control the group. Honestly, I don't interfere much. I just like supervise, make sure everything is fine. And I hope we're gonna continue the same way it is right now, but I'm looking for using or utilizing other social media platforms, such as YouTube as well. Perhaps creating educating videos or sharing experience of a patient if they're willing to share their experience and they're not shy off or feeling pressure to share it. This is going to inspire others perhaps to do the same.
And can existing group members invite others directly?
Initially, yes, this was an open privilege, or a privilege that was given for everyone.
Yes.
Then, because of the inappropriate addition to patients who are not, well, to people who are not cancer patients,
Right.
we limited this to certain ladies, and we try to identify the member before joining personally, either by one of the professionals or one of the survivor or the cancer patient. Yeah.
And do you have now written explicit rules for the group for new members?
Yes, every time we have a new member, we have our code of, let's say, of joining, and we post it so they follow, like, please do not send unrelated messages, please be careful with your language, and do not spread any incorrect information. If you want to shake fact something, say that you're shake fact something, but you're not sending it to the group. Yes.
Correct. I can see there's been a message from Alan saying he had to attend to a medical emergency and he's apologizing. Of course, he's open to any of the questions to be directed at him directly via his email or to myself or any of the organizing panel, and then we pass those questions on. Now, Dr. Abusanad, the need that you have identified is from the ground up. So you have identified the need from a group of patients, a particular group of patients that has been feeling left out and stigmatized perhaps, and you managed to create something using new technologies within a professional trusted partnership.
Yeah.
How far do you think can this grow without losing that trusted element? Is this something, for example, that can attract members from other neighboring countries? Is this something that can go global? How far do you think this trust element is?
I'm going to share something with you. After I published the article,
yes,
and I posted on Twitter. Twitter is another strong social platform. After I published the article and I posted on Twitter, I received a request from a lady in UAE, the United Arab Emirates. She's asking me to join the group. So I just needed to confirm that she is a cancer patient survivor. And once I confirmed, I let her in. So it's been already outreaching to other people.
Oh, that's fantastic.
And crossing the border,
yes.
you know. Yeah. And I have a couple from Yemen also.
Oh, wow. Yeah. Oh, well done. Yeah. So do you think this can be applicable to other cancer groups, or do you think the breast cancer group is somehow different than others?
Maybe applicable for ladies in general. Breast or non-breast malignancies, because survivorship issues in ladies are quite different from gentlemen, and you know, cancer will affect the way they look, the body image, and the way they perceive themselves. So, and well, women are emotionally driven, so they need perhaps more support as well. Yeah. And they are very good in supporting each other and listening to each other and providing solution. And I would like to see a male model.
Yes, it's a very interesting observation. We're coming to the top of the hour, so I would like to ask you to provide a closing remark, if you have one.
Thank you very much. And I'm happy that you included me in this session. And definitely we are surrounded nowadays with, let's say, social media everywhere, and especially during these times with the pandemic. So we have to try to utilize them as much as we can in helping our patient, educating them, empowering them, and not only that, but also in educating ourselves and helping ourselves. And I think this is a great initiative, what you're doing. It's something that is hasn't been done before, paying attention and advertising innovation and use of technology in medical care.
Thank you. I couldn't have said it better myself. So thank you all very much for listening. This concludes the webinar on the innovative uses of communication technology within a medical environment. If you need to spread the word, the recording of this webinar will be available on social media platforms. We would like to thank once again the Innovative Healthcare Institute. Please check it out, and also the Innovation Express that collects and collates all the innovation in healthcare that is important and topical. I've been Dr. Zisis Kozlakidis. Thank you all very much for listening.
Thank you.
Bye-bye.
Bye.